Welcome to Public Forum, a community outreach program produced by North Idaho College located on Lake Coeur d'Alene. Featuring guests from around the globe addressing a wide variety of subjects, Public Forum serves to educate and enlighten. Please join host and moderator, political scientist Tony Stewart, in welcoming today's guests.
Today we start a two-part series titled The Cost of Abuse, Long-Lasting Medical Effects on Individual Health. And in covering that topic, we're going to talk particularly about abuse against women during pregnancy and the effects on their health. We're very fortunate to have on our program two highly qualified guests to speak to this very serious topic. I welcome to the program, first of all, Dr. Michael Rice. He is associated with Washington State University's Intercollegiate College of Nursing. Dr. Rice holds a bachelor's degree, BS, in nursing from Mount Marty College in Yankton, South Dakota. He also has a master's degree in nursing from the Psychiatric Mental Health Nursing at the University of Nebraska, and he holds a PhD in clinical nursing research from the University of Arizona. Dr. Rice, thank you for being on the program, and we look forward to interviewing you today.
My pleasure.
And I'm equally pleased to welcome to the program Dr. Kathy Records. She holds a baccalaureate degree from the University of Colorado in health sciences, and she also has a master's degree in her field of nursing from the University of Arizona, and she too holds a doctor's degree, graduating in clinical nursing research while studying the family functioning and caregiving of Anglo and Mexican Americans at the University of Arizona. Dr. Records, welcome to the program.
Thank you. It's nice to be here.
And as always, I'm very pleased to have our regular panelist, Janelle Burke, who's an attorney in the state of Idaho, and she shall commence today's questioning.
Thank you, Tony. Let's start with you, Dr. Records, on our program today. Let's talk about how you became interested in this subject of abuse to pregnant women.
Well, several years ago, I was teaching maternity nursing students in the hospital setting, and one of the nurses came out and said that she was going to have a very long day that day because her woman was in fairly early stages of labor, but not one that I would expect to be a really long labor. So I said to her, why would you expect this woman to have a long, slow labor? And she said, because she has a history of abuse. So when I left that day, I immediately called my colleague, who is an expert on abuse, and said, what do you know about it? What do you know about the effects of abuse on labor? And he said, I haven't seen anything in the literature. So we started doing lit searches and talking about what some of the ramifications might be, and that started all of it.
Now, Dr. Rice, when you talk about that kind of abuse, how do you define abuse? Are you talking about physical abuse, or are you also talking about perhaps some emotional abuse as well?
When we start talking about that kind of abuse, what we found in the literature was absolutely nothing. The most amazing piece is that we have this 9-month period here that socially everyone just accepts as a glorious, wonderful kind of time. The more we began to probe into this, the more we found out that we knew very, very little about the effects of abuse on any of this, regardless of what kind of abuse it was. We have a series of national consultants that we use, and some of them have dissuaded us from looking at certain types of abuse during this era because it's so difficult to study. But when we talk about abuse, we talk about really a whole range of abuse. We talk about childhood physical and sexual abuse. We talk about sexual and physical abuse during adulthood, and then the whole range of emotional abuse and the varying degrees of that. The focus of much of our work has been trying to tease out the effects of those kinds of abuse for specific kinds of outcomes. We really began to notice with some very fundamental building blocks about starting with labor, and then as we progressed in our work, we began to extend it back into the perinatal kind of periods.
With that, I want to go a little more into your research data. First of all, I commend both of you for moving into a field that has somewhat been ignored, and that's how we make progress with people with your credentials to do that. Statistically speaking, and some of the literature that we have from you indicates that The numbers are very disturbing, very high. Maybe I'll start with you, Dr. Rice, and tell us what you have found from that data. I know you have individual cases, one that Dr. Records just talked about, but how serious is this? And of those who are abused during that 9-month pregnancy, what is the percentage of rates that makes their giving birth so much more difficult, or even life-threatening, I assume?
Well, there are a whole series of things. When we began to look at this, one of our consultants, Dr. Judy McFarland at University of Texas, had done some preliminary work on rates of abuse and then really done some work on after delivery kind of follow-up. One of the big problems that exist is we don't have very good numbers on this. The numbers actually, the more we've done, have become more alarming, if you will.
In fact, just interrupt. So the
Sure.
data that you have is pretty much regional, is it, for the two of you? In other words, you're not tied into some kind of network of, at this point, of studies at different nursing centers and hospitals around the country. You mentioned the Texas, but
Yeah.
are we that much in the primitive stage of the data?
Yeah, yes, we are. We are in that much of a primitive stage. We have some proposals that we submitted to the federal government to do much broader studies, which we can probably talk about later. It's a little bit further down. In answer to your first question, though, yes, it is a primitive state. And initially, the statistics we had said somewhere about 13% were known and could be identified. So that became the first problem, is identifying who was abused and who wasn't. And the rates that we have really vary, anywhere from 13 to 26%
That have difficult, or have the abuse?
that are being abused. We know from the abuse studies that have been done by other investigators that during abuse, 25% of all battering begins during pregnancy. And frighteningly, at that point, the blows of the physical abuse switch from the head to the abdomen at that point, which is just an absolutely shocking and alarming kind of phenomena. What we were amazed with is how few of those are actually identified. At that point, we begin to look at several areas of healthcare, and we get into issues of what are called traumatic hemorrhage and miscarriage and loss, normal courses of pregnancy with the piece that we started with, which is particularly very long and difficult labors. And so we have to feed a number of those areas in to come up with a complete statistic on it. Any one of which is very alarming. In some of the studies, and correct me if I'm wrong, I think the highest we've gotten is like 26.7 in one of our samples
Percent that
that were abused. And again, because we're looking at a variety of outcomes, all the way from what are called fetal-maternal hemorrhage, which is the loss of an infant early in the pregnancy, to the effect on cesarean sections, which has become a large national issue in terms of the obstetric literature. The RAND Corporation about 1.5 years ago released a report where obstetricians were severely and profoundly criticized for the number of cesarean sections that they do in this country. In this country, we do about 21% cesarean sections, which is compared to like 10 or 11% in other Western developed countries in Europe. And the question then becomes why? And obviously with surgeries, people don't haphazardly jump in and do these kinds of things. Well, we have begun to build some evidence slowly that seems to indicate that some of these are partially related to what we call a failure to progress in labor, in which case the infant becomes terribly distressed and there's a need for that kind of emergency intervention.
So I'll move over to Dr. Records, and Dr. Rice has done a very good job indicating these statistics of the percentage from your studies, which is disturbing. And, any statistic, but when you get talking about 25% or a quarter, then of those Dr. Records that have been abused, then just looking at that sample, what percentage of those then are having real additional problems with the delivery? In other words, I assume there's some people, no one never justifies abuse, but I would assume that some women who have been abused, in spite of that, have a normal delivery. But what percentage from your study shows that it complicates? Or maybe don't?
I think that has to do with that article we're working on, where we're talking about in the absence of pelvic dysplasia and what the rate associated with dystocia directly is.
I can't answer that right now. I have.
You're too early in the stages of the research.
It may be there, but I don't remember what the answer would be.
Yeah. But you are indicating that of those who are abused, that they, on the average, that the delivery is much more difficult than for women who've had not been abused.
What we found is that when we compare the groups, the labors of abused women versus the labors of non-abused women,
Right.
that the average labor for an abused woman is 10 hours longer than for a non-abused woman.
That's very significant.
It's very significant.
But your numbers don't say that it's true in every single case, but
No, that's
overall,
the average.
the
overall.
average is over.
Yeah, so we may have some people that go into labor up to 36, 48 hours. I mean, there are people on the extreme end of the continuum.
Just as there are people then that balance them out with normal or shorter labors, but by and large, they're having much longer labors.
But that is statistically sound, is it not, to say? In other words, you have two samples. You have women who are not abused, and you have women who are abused. And when you compare those two samples, there's much more difficulty in giving birth, or the length of labor in the abused group.
They have more medical interventions as well.
Okay.
When women start having longer labors, we give them medication to try to get the labor to progress. They have significantly more of that medication. They use significantly more pain medications, and interestingly enough, they were using more pain medications not only during labor, but after labor in the postpartum period.
Okay, Janelle Berg.
I want to go back a little bit again to talking about what it is that causes this phenomenon to occur. You say some abuse begins during pregnancy, and if it has been going on, it oftentimes gets worse. I mean, there are figures to show that. And I take it we're only getting the tip of the iceberg because there are some non-reported cases, people who simply cover it up in all the usual ways that women cover abuse. Dr. Rickards, let's start with you again and talk a little bit about what you think is the phenomenon behind that. Why does abuse suddenly occur or gets worse during that period of time? Is it because of the stress of the relationship, do you think?
There's also, just to clarify, there's a group where abuse stops when the woman becomes pregnant. So there is that distinct set as well. From what we've read in the literature and people that work with abusers and with survivors, it seems that when the pregnancy occurs, that's a very much viewed as a threat. It's a threat to the abuser.
To the prospective father.
Right. Mm-hmm. And it's very stressful. I mean, most women, their first reaction when they're told they're pregnant is, oh no, not me, not now. Even if they very much wanted to be pregnant, it's stressful for any woman, but particularly in a relationship where there are other factors going on, it adds dramatically to the amount of stress that's experienced.
And in those cases, Dr. Rice, where it has been going on and now it becomes more pronounced, is there an escalation of the amount of violence as well, or is it in the number of occurrences that the abuse occurs, or is there a distinction, or does it just happen, however, in depending on the individual case?
I would like to give a generality and even talk about an average to that, but I don't think that we have enough data on that yet.
So let's talk about some specifics. If you've seen a specific situation where you thought it became then more pronounced, more violent, more, and either one of you can answer that question if you can think of one of your persons who were in your categories who might have expressed that.
I don't think that's been our focus. Our focus has been more looking at the long-term effects of any type of abuse. So you're focusing on abuse that's occurring during pregnancy. There's also a whole category of women who were abused when they were children and then may not be currently being abused, but we are seeing in those women who are survivors still health consequences for them. So we're looking at the general outcomes from abuse rather than...
I think it's a very good question. Unfortunately, and this is kind of where our data murkies everything up, and one of the reasons we get into the long-term consequences of abuse, we have been unable in any of our studies to tease out the difference between people who've been physically and sexually abused as children versus those people that have been physically and sexually abused as adults, even if the abuse stopped at the point pregnancy began. And that's a rather distressing kind of phenomena, because it means that regardless of when the abuse occurred, we have some very serious health consequences. You know, Dr. Reckerts mentioned the longer labor. Just in terms of fiscal cost, we did a very rough estimate for one of our studies and estimated that it cost approximately anywhere from $2,000 to $3,000 more for a normal vaginal delivery. Now, that doesn't mean people that have C-sections or anything else, just the direct cost of hospitalization and a rough estimate of the medications, because people don't respond well. But the ability to sort out at this point, there doesn't seem to be a difference, which is probably the more distressing piece, is that regardless of when the abuse occurred, even if it stops right at the point they discover they're pregnant, the health consequences to the mother and eventually the fetus are still dramatic.
So then do you also, have you looked at all at the postpartum situation? Is it greater in those people who are feeling some abuse or have had abuse in their lives?
Is
the postpartum, are they more likely to have some kind of postpartum distress?
Absolutely. We did a study where we followed women for 6 months postpartum, and the abused women had significantly more depression up through 6 months postpartum. So at least our data has shown those differences. Other studies have shown that something as simple as how the infant grows, you know, we have different categories or different time periods where we want to see weight gain. We see it doubled at a particular time, tripled by the end of the first year. Infants through 1 year of age who have grown up in homes where there's abuse, even if the abuse stops, are slower to gain weight than those that grow up in homes where there hasn't been abuse. So we see some fairly, and that's very good documented evidence for that particular phenomenon.
Your question is particularly relevant to this whole population, because when we began to look at the reasons, the medical reasons for why someone would have a longer labor, we began to investigate the neuroendocrine system kind of phenomena. And there's a theory that we use called Selye's stress response theory, which in essence says that after a period of high stress, people's bodies fatigue, which made great sense. And as we began to think about it, we thought about this postpartum issue. And as we began to find it just made sense, because the neuroendocrine system's involved in depression, that there would be a higher rate of postpartum depression, and indeed there is. There it begins to get a little complicated, because we have two very different groups of literature on postpartum depression. We've had some rather heated discussions about this from our different perspectives. One set of literature is the literature that Kathy deals with, which is the obstetric gynecology literature, which really sees people only up to about a month or two after the delivery and then discharges them into wellness kind of centers. The literature I'm familiar with is the psychiatric literature, which really begins to demonstrate that as much as a year to a year and a half after the delivery, we can see postpartum depression. And as we all know from the recent headlines and stuff, these forms of depression can have very profound and serious effects, not just on the immediate family, but the larger social system. And so finding the extent of how far it goes is hard, because we don't have really a provider service that tracks people after delivery for a period of time. They'll be discharged from the maternal child area and show up in psychiatric circles about a year and a half later. And so our study, where we tracked them for 9 months, is most unusual because there haven't been a lot of studies that have really followed people longitudinally and tracked what the percent and what the rate of postpartum depression is for these abused individuals. The correlation that we found is actually quite high. It's about 0.6, which just as a statistical thing, it's a fairly strong correlation. It means there's a fair risk postpartum of developing depression if they've had some form of abuse prior in their life.
You know, your studies are so significant, and I know that there's much to be learned yet, and it's very disturbing, and it produces lots of questions for us, and of course we'll continue some of this next week, but I just want to clear up a couple of things, being a novice with your information. And when you indicated that if a woman is not abused once she becomes pregnant, there's still that effect. My clarification is, how far do we take that back? That is, suppose from the time of her marriage and with her spouse, she's got a wonderful spouse and there's been no abuse during her marriage, but she was abused as a child. Does that still become a factor, or is it, your studies show that if she was abused in her marriage and then it stopped at pregnancy? I mean, how far back do you have any data to indicate that could it affect her pregnancy, even if it was just the abuse was confined to her childhood?
Yeah, well, we can't differentiate that.
I see.
In other words, the effects of someone who's presently being abused and their health on labor at this point in time looks exactly like people who have been abused as children.
So it is a lifelong effect upon them, both physiologically and maybe even psychologically?
Well, we don't know if it's lifelong because we're only looking at the childbearing period, but we do see differences.
Yeah, and perhaps in follow-up to your question, one of the most disturbing pieces about this is the newer pieces on some newer literature that are coming out. As Dr. Records indicated, the children that are born to these women have much lower birth weights. All right.
So there's a physical effect on the child.
They're much smaller, right? And they have much lower APGAR scores, which is a rough test of how oxygenated they are. Okay. From the child psychiatric literature and the follow-up literature on low birth weight infants, we're finding some very disturbing kind of facts coming out that we're just now starting to try and build into pieces of our research. And that is that these children, not only do they grow slower, etc., have significantly more social problems. And by social problems, I mean the things that trouble us all in terms of behavioral issues, in terms of learning disabilities, in terms of drug use as adults and children. I just read a report last night about an association between APGAR scores and rate and form of suicide, in that children who are particularly low oxygen levels at birth have a high rate of using asphyxiation type of mechanisms to kill themselves as adolescents. So yeah, we begin, even though we don't know some of those pieces, when we begin to stretch together not only our work but other people's work as well, we see how these really become not just lifelong things for the women, but lifelong things for society as a whole.
So may I
serious consequences.
Go back to Dr. Records for a moment, and we don't have a lot of time, but we'll be back next week. But I hear from the comments that Dr. Rice has made that we're just beginning to discover the incredible implications that are social and economic and ethical and all these questions. That is, that a woman who's abused even as a child, that's long lasting, with the pregnancy, and affects the child, and therefore the most important point is that what this does to human beings, the women and their children, and then also there's this economic price of larger medical care, not only for the delivery of the child, but it may be in that child's life. I guess one of my questions in trying to summarize that is, do you find, and I appreciate the fact that your research is early in its formation, but are babies born in those situations, for example, more hyper and more restless as young children? Or am I getting the area that you haven't pursued
Oh,
yet?
no, that's an excellent, excellent
Good
point.
question.
And that's a study that we're going to start this spring because that is a logical conclusion. We would expect them to be much different than the babies of non-abused women.
Not
and we
as
would
tranquil and...
Exactly. And the other piece of all this, that it's very discouraging, but we're very hopeful that if we can find some of these links and some of the underlying causes, then we're able to develop interventions.
Yes.
Excuse me, and the interventions will help change some of those health outcomes for these women and their children.
I react to that immediately, and again, Janelle will pursue some of these on the next show, but if your findings, which I assume they're going to, is going to continue to be more and more powerful to show this seriousness, well, number one, a person shouldn't abuse another person, but the men who have done this, for example, is there any chance when they understand this, even though they've been so wrong with their spouse, will it check their behavior if they have any concern about what's happening to the child? But that, your intervention is, everything you can do in intervention to stop the abuse is helpful.
And right now, we're leaving the people who work with abusers to do that particular
Okay.
piece. We're really interested in focusing on the women and their children and what interventions we can do during the prenatal period, maybe what we can do with them when they come in for labor and delivery, and then what needs to change in the healthcare system to follow them postpartum.
We're out of time, but I can say that certainly that data that you have could be taken and given to those who are involved with the intervention, and maybe that could be another tool for them to use. On behalf of Janelle Burke and our staff, I want to thank Dr. Records and Dr. Rice for being with us, and thank you for coming back next week, and we'll continue to talk about this serious topic. Ladies and gentlemen, as you know, we've been talking today about the issue of the cost of abuse, and particularly our concern has been about pregnant women and what happens to them and their infants. And we will continue this next week when we bring you part 2, the closing part of this 2-week series. We like to oftentimes bring you more than 1 week on a serious subject. We feel we cannot cover everything in 30 minutes, and that's why we do the series 1, 2, and sometimes even longer. And again, I hope you'll be with us again next week at this same time when we'll just pursue this subject. Until then, please have a good week. I am Tony Stewart.
Recorded on the campus of North Idaho College, Public Forum is the longest-running entirely college-produced program on PBS. Each episode is pre-recorded live and is an educational outreach from North Idaho College. Please join us again at this same time next week for another edition of Public Forum on this public television station. Welcome to Public Forum, a community outreach program produced by North Idaho College located on Lake Coeur d'Alene. Featuring guests from around the globe addressing a wide variety of subjects, Public Forum serves to educate and enlighten. Please join host and moderator, political scientist Tony Stewart, in welcoming today's guests.
We welcome you to part 2 of our 2-part series titled The Cost of Abuse, Long-Lasting Medical Effects on Individual Health. On the program last week and again this week, we are focusing on pregnant women and if they have been abused, what consequence that has for their health and the child. We're very fortunate to have on our program 2 experts, and we commend them for this research. It's really a new field that unfortunately has not been covered by research very much in the past, and we commend them for doing that. First of all is Dr. Michael Rice. He is with Washington State University's Intercollegiate College of Nursing. He holds a B.S. in nursing from Mount Marty College in Yankton, South Dakota. He holds a master's degree in nursing from the University of Nebraska, and he has his Ph.D. in clinical nursing research from the University of Arizona. Excuse me, Dr. Rice, welcome back to the program, and
Thank
we
you.
look forward to the continued interview. Also on the program today is Dr. Kathy Records. Excuse me, with my cold. She too has a bachelor's degree, and it's from the University of Colorado Health Sciences Center, and she holds a master's degree in nursing from the University of Arizona, as well as a doctor's degree in clinical nursing research. Dr. Records, welcome back.
Thank you.
And as always, we're very pleased to have our regular panelist, Janelle Burke, and she will commence today's questioning.
Welcome back to the show this week. We had a very interesting discussion last week about the effects of abuse on pregnant women, and we're going to continue that discussion. You also have done a great deal of research together, and one of the studies has to do with the effects of childbearing experiences of Hispanic women. And so let's start with you, Dr. Records. Kathy, can you tell us about that particular bit of research that you did? And then also, Dr. Rice, would you go in with Kathy and talk about that particular study?
This was a study we did in the Central Corridor region of Washington State, and we talked to, it's a qualitative study, so it's a smaller sample size and involves interviews. We talked to 7 abused Hispanic women. 2 were Spanish-speaking only, 5 were English-speaking as well as Spanish-speaking. And we asked them to talk about what their childbearing experiences were. And then in looking at the data and analyzing the data, we came up with some of the normal things that you would expect any woman who had a baby to say. Women were worried about the health of their baby. They were worried about how much pain there would be. They were afraid of the pain. They experienced pain and perhaps some fetal distress during their labor. And then there was a couple of other things that occurred. They indicated that they either had very supportive or unsupportive families, and obviously if they had or were still in contact with abusive people, that would be more unsupportive to them. But we would see other things from this group described as unsupportive statements. For instance, women being told how bad the labor was going to be. They didn't want to hear that when they were pregnant. They found that to be very upsetting, and so there were unsupportive statements. But then the most striking thing that emerged from the data was probably a series of responses that we don't see with non-abused women, where these women reported depression, anxiety, and panic related to their childbearing experiences. And this occurred as well during labor as well as somewhat in the postpartum period.
And the panic's particularly disturbing because, as we talked about last week, we talked about this neuroendocrine kind of change. And the more that we've done on this, the more we've drawn parallels with the classic post-traumatic stress disorder syndrome that we see. And there are a lot of very serious similarities between what these reports were and the PTSD phenomena. I think what's important for us about that particular study is that we followed it up then with a series of 5 or 6 Anglo women and did the same thing, all of whom had known and diagnosed postpartum depression. What is particularly fascinating is that their reports, particularly around this panic and anxiety state, are almost identical, regardless of the fact that one set's Anglo and another set is Hispanic.
So panic is very definitely, panic and anxiety is very definitely one of the things that can come from abuse.
Absolutely, absolutely. What one of the women in the Anglo sample described was her abuse as a child had involved being tied down. And when she went in to deliver a baby, she had a C-section. And because her panic was a little bit out of the ordinary and extreme, they tied her legs to the stirrups. And of course, at that point, she began to have flashbacks and immediately lost it. And again, while the samples are small, what we see is a rather disturbing set of similarities across all of the abuse victims in the level of panic that they have during labor and delivery.
My first question might be more appropriate for medical doctors, but you're the ones that are really delving into this very, very important subject. Thinking of from the data to this point is that it seems overwhelming that women who are abused, the facts are just there, that labor will be more difficult, there's more chance of miscarriage, and then you've also talked about what can happen to the child when born, growing slower and less weight. It's just really serious consequences. But in your communication with physicians, and you certainly are highly trained yourself, in the person that's been abused, isn't there certain physical changes taking place? When people are under stress and under abuse, I've heard medical doctors say that, for example, even stress at work and all, that it can secrete more acid and have ulcers and so forth. So is that part of the explanation that the woman is under such duress that there's a whole physical change which will affect the formation and the growth of the fetus?
I think what you've hit on is probably one of the key focuses of our future studies.
Okay.
We know that just being pregnant causes a series of very natural changes in a woman's physiology, many of which are identical to that of a high-stress individual. Teasing out which ones have been induced because of the abuse versus which ones are part of the normal pregnancy course is very difficult and still hotly debated.
Because there are people who are not abused and they have difficult pregnancies too.
Yes. What we do know is that one of the major stress response hormones can be as much as 2 to 4 times higher in women who are abused during labor than women who are not abused. We have recently entered into some discussions with a colleague in Texas who focuses on preterm deliveries. And we're looking at a series of combined studies to see if we can identify for her these cortisol hormone levels, and for us the abuse piece of her preterm deliveries. We know that high cortisol levels, or the stress response hormone, is very prevalent in women who deliver very early, but there is absolutely no data whatsoever about whether or not those women have been abused. We have no indication whatsoever.
You keep saying things that brings other things to mind for me, and I'm certainly not a researcher in the field of medicine, but Dr. Records, we've known for a long time from physicians and experts in the birth process that women are advised not to smoke cigarettes or to have a lot of liquor and so forth during pregnancy. That's already been out there, and there's a lot of work on that. So in your research now, are you kind of paralleling those studies, the consequence we found there, and are you going to be communicating, or have you, with physicians and others to say, okay, we already know about nutrition and good sleep and all, but then this is another path that can accompany that. In other words, down the road, maybe you can be as effective getting the word out that this is another aspect of good health before birth.
I would certainly hope so, and we've been very fortunate to have develop some very good working relationships with the obstetricians both in Spokane and in the Yakima area. And whenever we complete a study, we do provide either a presentation back to them or the articles and the results, so that they can look at what we've done so far, what the results are, what still is a little bit in question, and where we're going, and provide some feedback to us on if they think we're on the right track or not.
What are they saying to you so far? I mean, they must be really interested in this, because we
Very
know how
interested.
they feel about
They've
nutrition
been great.
and all.
They've been great.
Yeah. Janelle Burke.
Now, you have to identify these folks, and so is there a means of identification? And Michael, I'm going to address my question to you. How do you identify someone who might have been abused?
Identification of these women who've been abused has been a serious problem. And this is in part when we talked with Dr. Judy McFarland in Texas, who's done a lot of this work on early identification. And the rates are real low. Identification is as low as 13%, even though the actual incidence may be twice as high. She's developed some strategies where they can increase that reporting rate up to 15-20%. And then the Center for Disease Control also put out some standards where they recommended actually interviewing the people 3 times serially and found a higher increase in the reporting rate. At best, the accuracy is roughly around 25 to 30% in those studies. We just completed a study and have submitted it for publication where we look at, as Ms. Stewart indicated, some of the physical changes that are associated with this, some of the basic stress responses. This is a very simple cardiac rate study where we studied 4 groups of people. We had healthy hearts who'd never been abused. We had women who were abused and not pregnant, women who were pregnant and not been abused, and women who were abused and not pregnant. And we found that the cardiac rate changes are so accurate that it can identify roughly about 72% of these people on the first prenatal visit, which gives us a 9-month jump start on some of the long labors and postpartum depression and child fetal issues. The other thing that related to that, we've just started investigating, and I'll tell you what I know about this because it's not, in terms of the effects on labor, not really my area. But in looking at the data, I noticed that we have significant elevations in blood pressure as well. And what's called pregnancy-induced hypertension is a real problem in labor and delivery. And yet we've got this whole population here that don't have pregnancy-induced hypertension. They have pre-existing hypertension or abuse-induced hypertension. And I'll let Dr. Records talk a little bit more about that effect on pregnancy.
That's what I was just going to ask. Why do we need to identify people? Is it important that we know about it? What can we do if we do know about it?
If we know about the abuse?
About the abuse, yes.
If you know about the abuse, then you're able to get in earlier and intervene. And we know that many of the women are not going to leave their spouses. They're not going to leave the situation. But as healthcare professionals, there still ought to be something that we can do. And if it is indeed the stress response that's triggering the negative consequences for them, then that leads us to interventions to decrease the stress response. And there's a whole variety of things we can do during pregnancy and labor and even the postpartum period to decrease the stress response.
Some of those, I'm sure, would be counseling type things, but there are others that would be medical type things, perhaps how you would use medication, how you would anticipate the length of the delivery. Because last week we learned that deliveries are significantly longer and much more costly for those people who have been abused. So you would start using that, and I take it that would go along with the hypertension.
That's right.
You're going to deal with that hypertension more carefully, perhaps, if you know it's an abuse situation.
There's also all the alternative medicine techniques that would be very much appropriate to help decrease the stress response, from massage to therapeutic touch.
The information was given me, and I want to express our appreciation to the women's organizations in North Idaho that brought you to our community for a public forum, and we had you on the program because of that. One of those handouts indicated that one recent study documented that 1 in 12 pregnant women has been battered during her pregnancy. That's a frightening statistic.
Those are national statistics.
Those are national statistics that came from that, and you're using that kind of data as you look at your region and what you're doing.
That's right. As we begin to look at actually any of the studies, whether we do it here or work with our colleagues in California or Texas, we use those kind of as our benchmark to begin building on rates and those kind of things.
So, such a high statistic, that means that we have, if we could solve this problem, of course the great thing would be the health of the mother and the child, but you could really alter greatly what's going on in dealing with pregnancy. That is, in the amount of hours that the medical staff has put in, and longer labor and more difficult births, and secondly with children afterwards. So we're just talking about a tremendous medical challenge too, aren't we, Dr. Records?
Absolutely. There are so many different facets. Just looking at a normal pregnancy and the interactions between the mother and the fetus and the things the mother ingests, as whether it has an effect on the fetus, and then you bring in this whole abuse issue and the social impact that it's really frightening to think that the fetus can be affected by the abuse that's done to the mom. But that's where we see so much hope for interventions in the future to improve their health.
That's right. There's a physician at I believe he's at Baylor, Dr. Bruce Perry, who has a very impressive website. He's a child psychiatrist, and he argues quite vehemently that much of the child mental illness phenomena that we see these days is directly related to what he calls fetal mental health. And, you know, again, as I mentioned last week, this is traced to a lot of these lower birth weight kind of infants that we know are associated with abuse during pregnancy. And so it really becomes an area where we do want to identify, we do want to begin to investigate interventions, because the ramifications are so broad and extend over really such an extended period of people's lives. Unfortunately, because we have often viewed pregnancy as this glowing special time, I think sometimes we've overlooked pieces that may be causing us greater problems in the long run.
I'm certainly not wanting to suggest simplistic analysis, but the people who abuse, such as men who abuse their spouses or their children, there's a lot of deep-rooted social issues at work here. But have any of your studies indicated yet that if there is in the cases where their abuses take place, that in those pregnancies where particularly the husband or the father to be, and maybe even the mother, did not want the pregnancy, that is, some people are at times, sometimes the male spouse is very unhappy with pregnancy at that time. Does that increase the chances of abuse rather than those cases where both parents are delighted that pregnancy is taking place?
Our studies haven't looked at that, but
Okay.
other studies across the country have looked at that abuse is, I think, twice as more likely to occur if the pregnancy is mistimed or unwanted. So that certainly occurs.
What we found in our studies, in the longitudinal studies that we mentioned last week, is that there is a direct relationship between the frequency of abuse and postpartum depression,
Yes.
which unfortunately is then linked to the amount of abuse they had beforehand. So sorting out here becomes really difficult. We're kind of looking like varieties of oranges, if you will. Mm-hmm. But we haven't actually looked at the rates or anything like that. What we've done is we have looked at is the relationship between abuse postpartum and postpartum depression, which then of course has an effect on children and the environment and everything else.
Thank you. Janelle Burke.
Well, we've talked about a little bit about how many people have this particular thing happen to them, but I want to talk a little bit about the specifics of the kind of abuse and the kinds of results that those may have. If during the pregnancy a person is physically attacked, and the fetus is physically attacked, last week you indicated that the abuse seems to go from the head to the abdomen in those kinds of abuse patterns. Some would be, of course, physical abuse that would actually be something which might be harmful to the fetus, and the person would then have to present to the hospital in order to be taken care of. But there are other situations in which it may be that it's not discovered until birth, and that the amount of abuse is much less in degree, I suppose you would say. My question really gets around to all of this is costly. It's costly in terms of what it does to the child. It's costly in terms of what it does to the mother, and it's costly to the health profession in general. So I guess I'm asking for comments with regard to that, and I'll just throw it open to either one of you to comment on those particular aspects.
I think we're just starting to get an indication of how costly that is, and even what the mechanisms are, even in terms of degrees. You know, as Dr. Records indicated to Mr. Stewart earlier about the effects on the fetus, etc., there's two dimensions that are particularly relevant. One is the fetus is not an independent organism inside this woman's body. And what newer studies are showing is that as these stress hormone levels rise in the woman, the infant actually seems to try to fight it off, which is part of the theoretical explanation for why it's low. The other issue involved is on a study that we just reported, and I'll let Kathy talk a little bit more about this, but the effects of sexually transmitted diseases throughout the abuse period on the fetus itself. Some of which, like beta strep, are a little bit out of my area of expertise.
In one of our studies, we had a sample size of about 200 from Eastern Washington and the Central Quarter, and we found significantly higher rates of sexually transmitted diseases during the prenatal period and higher rates of beta strep during the prenatal period in abused women as compared with non-abused women. Some of those infections cause, severe consequences for the newborn, up to where beta strep can be life-threatening for them. So we think that there's another piece of the puzzle in that, aggressive intervention during the prenatal period needs to be accomplished. The thing I wanted to clarify, though, for your audience is that not every abused woman is going to have all of these negative consequences, that people are amazingly resilient and differently resilient, and that not everyone is going to have all of these. We're talking the average abused woman.
The other thing that we must clarify for the audience, too, is that every woman who has difficulties in her pregnancy is not necessarily abused.
That's true.
Correct.
That's true.
When
we talk about some of those things like long, difficult labors, we sort out those individuals that have cervical problems, that have breech babies that are positioned badly, that have pelvises that are too small. I mean, we sort out all of those issues. So there's a whole group of people over here that do have labor complications that are not abused, absolutely. And I think that Kathy's point is well taken, is that just because someone's abused doesn't mean that they can't recover. I mean, if that were the case, then we'd just stop right now. We know that there are people out there that fit on the positive outcome pieces and look like normal labor and deliveries. The issue is, what are the most serious complications that we have, and how do we make interventions to make them all much more normal and fall into these normal developmental curves for delivery and pain medication responses.
Certainly your data is very powerful, and as it comes more and more clear to the public what you're finding in your further research, that a woman who's just in her early stages of pregnancy and she hears about all this, and I know it's difficult sometimes, but if she can have the commitment and courage, then it'd be, and the spouse or the boyfriend, whomever, is not going to quit the abuse, it would be very, very wise for her to get out of that situation and to increase her chances of having a healthy child and also less complications for herself. And so I'm talking about intervention again, but those who do that, I know yours is your areas of research now, but certainly I would hope that those who do that would really encourage a woman. Number one, pregnant or not, no one should stay in a situation where they're abused. But maybe that will be also part of I'd just like to get your reaction to that maybe that will be part of the future intervention. I suppose there are women who would leave an unhealthy, dysfunctional situation on behalf of their child when they know that that is the consequence. I guess what I'm also asking is, maybe a lot of women don't know these consequences before, obviously prior to your research, that what the hazard for their child is too.
We didn't know the consequences, and I think that's kind of the point, is that someone had an observation that's kind of been nursing lore and mythology on the floors, and we just began to investigate it. I would like to say a couple of things, particularly for the audience, which is that if individuals are in abusive situations, because of these consequences, they need to tell their obstetrician. As we said earlier in the program today, so much of it is not reported, so much of it's not recorded. And the best chance they have for good, healthy delivery, and the best chance we have to refer them to counseling and do things that may make major changes, is to let someone know, particularly their obstetrician and gynecologist. And at this point, that's probably the best thing they can do for themselves and their infant in the long run, is let people know that this is going on so that we can begin to make some kind of steps and interventions. And as Dr. Records indicated with the sexually transmitted diseases, many of those are very treatable and very treatable during pregnancy. And if they're treated during the course of pregnancy, they don't need to run the risk during delivery of being exposed to those diseases for their babies. So it's well worth the test. And again, just letting their obstetrician and healthcare provider know that that's the risk factor.
We're just almost out of time, but I want to wish you good luck in your research, and I assume that you have some grants or you apply for funding, and I would assume the more that you get involved with this research, the more eager some foundations now would be to fund you on such a significant study.
We hope so.
But you've already had some grants.
We've had foundation funding, and
good
we're
work.
waiting for word from the federal government on a project that's submitted.
Oh, good. Well, good luck to you, and thank you both for being here. On behalf of Janelle Burke and our staff, we want to thank Dr. Kathy Records and Dr. Michael Rice, both with the Washington State University Intercollegiate College of Nursing, dealing with the issue of abuse in pregnant women and the consequences that has. And I really appreciate your being here. It's a subject we've not had before, obviously. It's new research, and we're very fortunate to be able to share that with our viewers, and I know it will be helpful to them. Again, good luck to you in your work and studies. You're to be commended. Ladies and gentlemen, this closes out our 2-week series on this very serious subject of abuse in pregnant women and the consequences, and I'd invite you to be with us again next week at this same time, and we will move to yet another issue for interest to you. Until then, please have a good week. I am Tony Stewart.
Recorded on the campus of North Idaho College, Public Forum is the longest-running entirely college-produced program on PBS. Each episode is pre-recorded live and is an educational outreach from North Idaho College. Please join us again at this same time next week for another edition of Public Forum on this public television station.